Thanks, Ben, for that. That's really useful to give us a kind of a policy context to put all of the great work that we're going to showcase today. I will move along quickly. We've got some great voices to hear from, and we've also got a couple of breaks. So I'm going to encourage people to do just as Ben recommended and ask their questions in those breaks so we can get to the end of the session. I'd like to first introduce Professor Didier Aswad, who is Chief of the Department of Psychiatry at the Centre Hospitalité de l'Université de Montréal and full professor at the Université de Montréal. Apparently, my French accent is quite appropriate for Quebec because it's quite weird. Didier has told me. As a principal scientist at the Chum Research Centre, Didier focuses on substance use disorders and their connection to mental health conditions. He leads multiple national clinical trials aimed at developing and evaluating effective treatments and care models. He's going to talk to us today about some of his work and about integrating psychosocial and pharmacological interventions for methamphetamine use disorder. Please, you come up to the stage.
Bonjour tout le monde. Alors, je vais faire ma présentation en français aujourd'hui. I'm kidding. But by the way, great French, amazing French. I'm extremely happy to be with you today. I would first like to thank Krista, Nadine, Liam, all the organizing committee for inviting me to be here. I'm very happy to be with you, well, for a number of things. First, you do have a wonderful country, a wonderful city, and wonderful people. I've been here a few days, and I've only met very welcoming, friendly people all the time, so you're very lucky. Probably you don't realize that because you live here, but that's a very, very, very special place. The other reason why I'm very happy to be with you today is because of this, actually, in this space. I come from North America. I'm Canadian, as you probably noticed from my accent, and we've been through a whole lot in the last few months in North America, and I'd say probably a situation where there's a lot of fighting, a lot of hostility, a lot of different ways actually to interact together between countries, between people, and I think that has also had an impact even in the science world and in the science community, the way we speak to each other, and even a country where we're, in Canada, we're quite usually recognized as a kind of a soft-spoken population and people. We've seen, especially in the addiction world, a whole lot of tension. People from addiction psychiatry fighting with people from addiction medicine background, people with harm reduction perspective and background fighting with people who advocate for recovery. Basically making this space incredibly hostile. And I would say probably not very a good space actually to find solution for people who use drugs. So I'm extremely happy and feel very lucky to be here with you, with, of course, people from different perspective, having different perspective, different background, people with different experience, clinicians, researchers, so that we can speak to each other respectfully and learn from each other. Which is, I think that's not mine, but I'll go through this. Oh, here you go, my presentation. You see here my conflict of interest. I'd like to acknowledge that I do live and work in Tiohtià:ke, which you maybe know is known as Montreal, on the unceded territory of the Kanyen'kehá:ka Nation, who's also known as the Mohawk people. And that is, for me, extremely important, because I think in Canada we've been trying for years, but I think we're just starting our journey on our reconciliation path, and there's so much to do, actually, to do better, actually, for our Indigenous people. The other thing I'd like to also mention is today, of course, as you'll see, I'll talk a whole lot about stimulant use disorder, and we'll talk about solution for people who use notably methamphetamine or other types of amphetamine who have developed over time problems related to their substance use, I think it's very important to remind ourselves that most people who use substances do not use it in a problematic way. And I think this is extremely important because I think that as clinicians, even as researchers, even when we're very well-intentioned, I think we can also contribute to keep stigmatizing people who use substances. So I think that context is, for me, very important. That being said, let's dive in. I'll talk a little bit about the Canadian situation. Of course, my not so hidden objective today is also to learn from you. There is so many great things that you're doing in Australia. You're far geographically, but hopefully you know how much you contribute to that field, and you're definitely in the leading countries in terms of the research you do and the clinical work you do. But to go back to Canada, I guess you probably heard a whole lot about the overdose crisis in North America and Canada. We've been hit quite hard by that, just like the United States, and we've seen thousands, and I'd say thousands and thousands of Canadians dying from overdose, mainly driven at the beginning by opioid and the toxic opioid supply. What we've seen, and that's on the left, what we've seen over the last 2 years is a situation that seems to be somewhat a little more stable and even potentially a slight decrease in the number of people who would die from opioid overdose. There's a number of reasons for that we'll not necessarily get into, but what you see on the right is actually the numbers for the number of overdose that involve stimulants. Actually, what you see is the decrease at the very end. It's just because it covers 3 months. So basically, over 3 months, I mean, we're on our way in 2025 to be much higher than 2024 in terms of the number of deaths. So what we're seeing basically in Canada is a slight decrease in the number of people who would die from opioid overdose, but we see more and more overdose related to stimulants, which, and some would say finally, brought to the attention of authorities, clinicians, but also the research community, even more the impact of methamphetamine and other amphetamine on the health and well-being of people who use substances. And some would say and again, those are things that you know very well because you've been, I think, experiencing that for a little while here in Australia, but kind of the perfect storm where you have a substance that is more and more potent, a substance that can be addictive and probably is a little more addictive than other substances, and that for a good number of people would lead to a number of consequences, not just in terms of the substance use disorder itself, but also in terms of their physical health, their mental health, their overall well-being, a whole lot of stigmatization, and that we can talk a whole lot about that. But if we thought, at least in Canada, that people were using opioid and were overdosing, were stigmatized, now what we're seeing is people who are using stimulants, of course, in the public space, being a little more obvious when they use are even more stigmatized. And again, as I was mentioning, quite a large proportion of our opioid deaths that are related to methamphetamine. So we have really the perfect storm also because, as you know, the clinical solution and intervention that we can offer to people who show up and wanting treatment are relatively limited. I'd say in Canada they are limited because I still think that even though, and that's what I'll talk about because I'm not so joyful right now, but we'll talk about solutions shortly. Even though we're starting to have stronger data to support the effectiveness of some intervention, even though we can do better, there's still a whole lot of clinicians who are actually still thinking that there's nothing to do when someone is using stimulants and is seeking treatment. So still, our solutions are relatively limited. So we have this perfect storm of a substance that is quite addictive, that can lead to a lot of problems and not so much to offer, or at least we can do much better in terms of the treatment we can offer to people who are actually asking treatment. This idea too that there's not much we can do is, I think, driven by an history of different, attempt to use a number of medication to treat stimulant use disorder. We have a number of examples, for example, modafinil, naltrexone. This is work from PhD student in the lab doing meta-analysis and showing indeed that those intervention for amphetamine type stimulant use disorder are not that effective. And unfortunately, I think that type of negative findings has really driven this lack of optimism in terms of what we can offer to people who use substances, especially stimulants. But, and again, we have some of the trials actually that led to those findings that I'll talk about in a few seconds are coming from Australia. But we also have a growing number of evidence and trials showing that there are a number of interventions actually that have been shown useful to decrease stimulant use. And for example, bupropion, whether or not it's combined with naltrexone, prescription psychostimulants, that's definitely a field we'll hear about later today. But meta-analysis showing that they do provide benefits and they do help to decrease stimulant use. So even though we had a number, I guess, of failed attempts using medication to treat amphetamine use disorder, I think we're starting to have growing evidence that there are some medication that can be used and that can help people. That led, among other things, to what I think was quite needed almost 2 years ago now. The Addiction Society of Addiction Medicine and the American Academy of Addiction Psychiatry jointly published the clinical guideline for the management of stimulant use disorder, which would include cocaine as well as amphetamine. And those were quite welcome because we've had a series of guidelines for opioid, for alcohol, for other substance use disorders. But for stimulant use disorder, I think we've been, as a whole and globally, a little shy about trying to provide recommendation and guidelines to clinicians because of probably to some extent the lack of evidence. And I'd say these guidelines, they're not perfect. And for those of you who read them, there are things that could be improved, but they were quite courageous in terms of getting experts together, looking at the evidence and providing some guidance about what can be done for people with amphetamine type stimulant use disorder and cocaine use disorder. And then you have, for example, those are the recommendation for amphetamine type stimulant use disorder, a number of medication, including bupropion, topiramate, mirtazapine, as well as psychostimulants such as methylphenidate that are recommended for amphetamine type stimulant use disorder. One thing that is, and I think that's definitely interesting and hopefully something that possibly we'll discuss today, is one thing when you look at the guidelines carefully, there are these little notes that are coming with these guidelines about the fact that if you want to provide those interventions and specifically psychostimulant, you have to be well trained, you have to be quite specialized in addiction training, you have to be able to provide a full addiction treatment kind of settings, which in some ways is important because these data come from trial that provided that type of intervention in settings. But this is quite challenging when you think about where are actually addiction treatment provided in, I suspect, Australia, just like it is in Canada. Often population are outside of large urban settings where sometimes clinics are not so have not all the resources that we can see in large cities. And so that also makes these interventions much more difficult and challenging to implement in settings where we find a whole lot of people with stimulant use disorder. One other thing that these guidelines are doing is providing us also about some recommendation regarding psychosocial intervention. And one thing that is very clearly highlighting is the fact that contingency management is the intervention for which we have the most robust evidence. This also comes with challenges, and I think we have a panel about this in a few minutes, because although we have quite robust data supporting contingency management, when it comes to implementing contingency management, then we have a whole lot of challenges, which leads to what I understand here, but also in most countries, contingency management being very rarely implemented in clinical settings. The other thing that these guidelines are doing that I think is quite interesting is to talk about concurrent disorders, and especially mental health concurrent disorders. And I think that comes from a very clear reason, is that when you look at the data we have on comorbidity, especially mental health comorbidity in people who use especially methamphetamine and other types of amphetamine, is that this comorbidity is extremely frequent. Some would say that it's probably sometimes more the rule than the exception. And these guidelines, even though, again, the evidence are relatively limited, really try to highlight kind of some recommendation on how to address both disorders, and at the very least reminding us how important it is to try to address both mental health and substance use disorders jointly, and not do what we've seen so much for so long, and that we see still, including in my country, in Canada, people showing up with a substance use disorder, a comorbid mental health disorders, and being told that they have to address one or the other, that they have to pick before getting some help. There's a number of also recommendation around psychosis, because of course, for those who work in the emergency room, that's a very common clinical presentation for people who are using methamphetamine, including those who would use very intensively or quite potent products. So these recommendations are, well, good in terms of telling us how important it is to think about those things and about addressing both mental health disorders as well as substance use disorders jointly and at the same time. At the same time, these recommendations remains very, very high level. And when you're a clinician, you have someone in front of you, often those situations, there's emergency, it's quite chaotic. Those recommendations remain very high level and are quite difficult at this time to really be implemented in real world setting, and to guide more specifically what clinicians should or should not do when they have someone showing up with a stimulant use disorder and also experiencing mental health problems. So it's good, it sends a strong signal about the importance of addressing both, but probably lacks the details that clinician needs when they really want to have and improve their practice with people who use stimulants. So you basically heard me a little bit. We have something great. We're starting to have recommendation, but mostly in the form of a list of intervention that we should provide and for which we have a certain level of evidence. I think that we can dream a little bigger than that. I think when we think about what we have now for other substance use or mental health disorders like depression, like opioid use disorder, like alcohol use disorder, we have, I think, much more sophisticated guidelines where we do have algorithm, we have a number of options, we can combine sometimes those options, we have recommendation about when and how to combine these interventions, and I think for stimulant use disorder, we're quite far from that. And when you think about, of course, when we do trials, it makes a whole lot of sense to think about intervention in terms of one intervention. We're testing it, seeing if it's effective. But when you think from the perspective of someone with lived experience who show up for treatment, who have sometimes other problems than purely the substance use, it really calls, I think, for a more comprehensive approach and probably for a more sophisticated way and guidance in terms of the treatment we should be able to offer people with stimulant use disorder. The first piece I think that is important is harm reduction. And we'll talk today about a number of interventions that we need to develop. We need to do much better in terms of the intervention we can offer to people who want to decrease or cease their use. And that's of course very important. That's the type of research I'm doing myself. But when you look at the data, even from the most robust trials we have, the vast majority of people in those trials keep using stimulants, even though they received relatively evidence-based intervention, which means that even in the context, highly controlled context of a clinical trial, we have a whole lot of people with ongoing substance use. So I think we have to think not only the way we provide clinical treatment, but also the way we conduct clinical trials to make sure that those participants in our trials are safe. I think we also have a whole lot of work to do in terms of the harm reduction for stimulant, and I'm more than curious to hear about how you're managing this here. But in North America, I'd say the vast majority of our harm reduction initiatives were thought with opioid in mind. So we have naloxone, for example. We have safe consumption sites where basically everything is thought in terms of the overdose, respiratory depression, and whatnot, and very little about actually what happened when someone who's using stimulant is overdosing, and sometimes, of course, which does not lead to sedation and respiratory arrest, but more behavioral disturbances, agitation, and distress. So I think we even have to think about how we do harm reduction, adapting it to stimulant use disorder, but even most importantly, I think when we conduct stimulant use disorder type of clinical trials, we have to think about how we integrate these harm reduction intervention to make sure that our participants, not only we test intervention with them, but we also make sure that they stay safe, knowing that the majority of them will actually still using during and after this trial. I want to go back to mental health care because I think that probably for stimulant more than other substances, again, mental health is extremely key. My clinical experience, but also when you look at the evidence, first, like I said, mental health comorbidities are highly frequent. And it's actually often why we see people showing up in treatment settings. And sometimes it's not to address their substance use. Sometimes because they're brought to the emergency room because they have psychotic symptoms, because these people are in acute distress because of their use and whatnot. And it leads, I think, me and others to think that we should treat mental health and consider mental health comorbidities as really part of amphetamine type use disorder, and making sure that we provide these intervention in a more integrated manner, and do not wait, hopefully, years and years before starting to think about addressing jointly both mental health conditions in people with stimulant use disorder. Again, the challenge we have is the evidence for now is quite thin. Other than saying that you have to address psychosis, yet you have sometimes to treat with pharmacology, there's not much else in terms of very specific guidance for how long you treat, for example. What's the type of care you should provide with someone showing with what would be a very specific amphetamine-induced psychotic disorder? Should you address this just like any psychotic disorder? Should the treatment be less intensive? For how long? That type of question. And I think we have to do much better and probably develop specific research initiative trying to provide ultimately this guidance, this type of guidance to clinicians and people with lived experience. The last piece, I think, and the big challenge I think we have comes from, I think, probably years of, when you look back at these years and decades, actually, of finding intervention that are effective for, including for methamphetamine use disorder. And I think we have to be realistic. When we look at these trials, usually testing one intervention, specific medication, specific psychosocial intervention, often those trials were negative, or at best, we saw a relatively small effect size, which means, and again, except if we find a miraculous treatment tomorrow that will be much more efficient than everything we tried so far, we're probably in a situation where each of our intervention may be helpful, not for everyone, and if it helps, it's probably only solving part of the problems. And I think that really that calls for probably trying to be a little more sophisticated in our way to try to address this gap and probably try to find ways on how can we provide the best integrative and comprehensive care for people with methamphetamine use disorder. And I think that one potential way is to try to combine treatment. Combining treatment, of course, when you're from the perspective of someone with lived experience, or if you work clinically, that makes a whole lot of sense. When you have someone showing up in a clinical setting, rarely will just provide one intervention and just let the person go. Most often, actually, we'll offer and we'll discuss potential options. We'll usually combine both psychosocial intervention, pharmacological interventions, and I think the spirit of that is also because all these pieces, if they're well designed and well integrated and well combined, are possibly more likely to provide benefits for the person who's seeking care. And I think that that's something we have in our research effort to take into account and try to develop much more. And I think we have opportunities here. We have, for example, some intervention, probably more psychosocial intervention, who are probably more effective to engage people in care and having people showing up to treatment. We may have, for example, pharmacological intervention, who are probably much more effective at decreasing withdrawal symptoms, preventing relapse, decreasing substance use. So I think we have opportunities here to combine different type of intervention, and if we do it in the right way, eventually potentially increasing that effect size that we've seen in studies thus far. But that, of course, is not easy. When you're doing clinical trials, of course, and designing these clinical trials, the more you add layers, the more you add treatment arms, of course, the more you increase sample size. I don't know how is the funding for research. I'm the perfect person here in front of me. How is the funding for research here in Australia, but even in supposedly rich country like Canada and the United States, often trials are underfunded. So you basically end up with having 70% of the funding you really need to conduct the trial. So which makes, you know, these very complex trials where you would have multiple arms quite complicated to conduct. There is also, I think, what is quite complicated when you do that, the combining intervention, especially when you try to combine psychosocial intervention with pharmacological intervention, it also brings a level and a risk of heterogeneity. When you have multiple psych trials, for example, it is quite complicated to try to make the treatment everywhere the same, which is of course, quite important and has a lot of impact on your ability to detect a potential difference between treatments. So doing that type of research is not easy, comes, of course, with some risk and is quite challenging. It also calls potentially for larger trials, and that's also why I think collaboration within country, but also between countries is so important, so that we're able to conduct larger trials where we test probably more different type of intervention, and we're combining them in a careful way, so that potentially we may come to a point where we have a better intervention to suggest and offer to people who are seeking care. One thing we've tried to do, and I think it's kind of a very, and with a lot of humility, a very humble first step towards that combination approach that I've tried as well. We're not pretending here that it's the first time. And again, presenting here this trial that we're conducting in Canada, not trying to sell you the result of these, because it's still ongoing. So we don't know if it's working. But what I'd like to do is a little bit of the thinking and how we came to developing this trial and what we're hoping for. And so this is the ASME trial. The ASME trial was developed in Canada, coming from a call from our funding agency, which is called the Canadian Institute of Health Research, jointly with our network in clinical trial, which is called the Canadian Research Initiative in Substance Misuse. And basically what we did is apply for funding and basically really developing a trial, including, of course, with a vast network of researchers, but also co-designed with people with lived experience. So responding to that call, we really went to the drawing board and discussed internally, looking at the evidence for the potentially best intervention. At the time, of course, we saw that contingency management was one, psychostimulant was another one, but there were other options as well. And we did quite I'd say quite an intensive consultation process, also with people with lived experience and leaders from across the country, discussing about the potential option. And those discussions were quite instrumental, interesting in terms of helping us design this trial with actually people with lived experience telling us that contingency management would potentially be acceptable, but if and only if the outcome and what we would provide incentive for was not abstinence. A whole lot of people with lived experience told us actually that that would be quite helpful for them to help them engage in treatment, especially if that was what we were providing incentive for. They help us also to design actually the type of contingency management we would provide in terms of the type of incentives, meaning money here, and also the schedule for the type of contingency we were providing with increased amount of money every time they were showing up for treatment. We also co-decided with them the type of among the medication and came to this idea that actually psychostimulant and iodose stimulant, a little bit at the time actually the trial was conducted here in Australia, and we had a lot of discussion actually with our colleagues here, and thank you Nadine again for this, leading us to pick that medication. And so what we came up with is a 2x2 trial where we are actually, and we're about a third in the trial in terms of enrollment among 440 participants, administrating treatment as usual, and quite a robust treatment as usual, where people will receive social support, motivational interviewing, some relapse prevention intervention, as well as harm reduction, and could be combined with either placebo or high-dose lisdexamfetamine, and also contingency management, but a contingency management that is very specifically targeting engagement and treatment. So people would get incentives to show up to care and receive treatment every week during the maintenance phase. So we're currently doing this trial, about a third in the recruitment at this point. So of course, nothing to report in terms of results. Of course, I'll be more than happy to informally, and especially in the contingency management panel, provide you with some informal insight about how things are going, if time allows. Another thing that we're doing is having a qualitative study alongside the ASME trial to really try to understand a little bit what the experience of people, especially in the context where not only we're providing medication, but we are also providing a form of contingency management that is not targeting abstinence, and especially the combination of both. So we really wanted to get insight from people who were participating in the trial about their experience of that combination when they were receiving it, and also their experience of contingency management, knowing that this has not been historically always accepted by people who are seeking treatment. The other piece that we're doing now is also an extension study. So, of course, this study is a 3-month administration study, which is, in terms of clinical trial, quite usual, but when you think clinically, very short. So we're currently doing an extension study where we provide for an additional 6 months medication to really get a sense of, with long-term administration of that high-dose stimulant, whether or not that could provide some benefit, and if actually people would keep coming for their treatment. I want to say, and maybe I'll end with that, is this is just an example of a trial. Of course, if we're thinking about having a much more complex algorithm of treatment and having different type of intervention that we can offer, that calls for, of course, a global effort in terms of research. We need multiple countries. We need Australia. We need Canada. We need Europe. We have colleagues in Vietnam who are doing research. So we need to do these trials. We need to all work together. We need to have different type of trials that are conducted. And I think also, and maybe that's a dream, but maybe eventually we need a multi-country trial where we all work together, doing this research, implementing these interventions in different type of settings, being probably able to reach a larger number of participants so that we can get more robust findings that could eventually help people who have stimulant use disorder. So a few things. First, and again, that was a short talk, but I think that, and that's especially for my colleague clinician, I'm still a clinician in my day job, I think we have to raise the bar. I think for too long, we've been telling people who are showing up for treatment with stimulant use disorder that there was not much we can do, and actually that's not true. We now have guidelines that tells us that there's a number of things. It's not perfect, but still it's much better than nothing, and that's the evidence, and that's what they're telling us. I think that we have to think about, and of course we need to build the evidence, we need to have very robust trial, we need to test these interventions one by one, but I also think that we need to start building what ideally would really, I think, best serve people with stimulant use disorder, which is a much more comprehensive continuum of care, potentially eventually, as I said, combining intervention, trying to find ways on how best to combine these interventions to reach best outcome. I think, and again, that's what I mentioned, I think especially in the case of stimulant use disorder, we really have to be quite proactive about addressing mental health problem. Even in the context of a clinical trial that would mainly try to address substance use disorder, I think we cannot allow ourselves not addressing the mental health comorbidity that is often actually the reason why people are seeking treatment. The other thing is I think we need, in addition to be able to try to combine these treatments in the best way possible, I think we need to start also being able to individualize treatment a little more and trying to get a sense of for whom these treatments are most effective, and depending on the individual characteristic, of course, what they want to receive in terms of intervention, but in terms of the severity of the substance use disorder, in terms of their mental health comorbidity, trying to do more individualized treatment and finding actually for what type of characteristics could lead to better outcomes. And that I think we can do notably based on the available trial. That's a research effort we can do, but also thinking about those factors in future trial we're starting. And maybe the last piece, and I think that's quite important for me, is to try to unite recovery and harm reduction. I've seen those fights. I told you about the fight we have in Canada. I've seen actually some papers from Australia where I was seeing the same fight as if we have to choose, as if we have to pick. I mean, why? We have different perspective, we have different treatment options, and why try to combine all this together instead of the fighting between us. I'll stop here by saying thank you to everyone in my team and colleagues who are working with me on this. Maybe a quick hats off to two people, Alexandra de Kiewit, who's a person with lived experience, the photo on the left, and Carole Morissette, who's a public health colleague on the right, who passed away in the recent years. Two people very important in Canada and in Quebec, where I live, in the field of stimulant use disorder, who contributed to the ASME trial, but a number of other things. And thanks for having me.